All right, everybody, we're back with our second half of chapter 19. So keep in mind the first 6 or 7 slides of our first slide deck are the intro chapter, or the introductory material for this chapter. It kind of applies to both systems. And then we went into the male reproductive system. Now we're going to conclude with the female reproductive system. And so back from our function slide that we see on every single one of our chapters, there was one that went with only the female system. So think for a second about that and see if you can kind of remember from our most recent lecture. So if you said that third bullet, the development and nourishment of a new individual, you would be correct. So both systems produce gametes, both systems produce sex hormones. Both systems have to contribute to fertilization, of course, but only the female system is equipped to be able to develop and nourish a new individual, of course. Okay, so we're not going to go through all the intro material again. We're going to jump right into our actual female reproductive system information. So here's an overview of the female reproductive system. You have the ovaries that are connected to the uterus via the uterine tube and the vagina itself. And then keep in mind the mammary glands in the breasts are also part of the reproductive system. And part of that is because they're not really active until the hormone changes that come along with pregnancy are in the mix. And we'll talk about that down the line a bit. So just like the male system, we'll go through all of our different kind of parts and we'll discuss the hormone changes and differences from the female to the male system. So if you remember, we talked about a few hormones like GnRH, gonadotropin releasing hormone, luteinizing hormone, which was LH, and follicle stimulating hormone, which is FSH. Those all come into play in our female system as well. But of course, because we have different anatomy, the physiology side of things is going to be different as well. So we'll talk about that. We'll also talk about some differences, just like in chapter 18, in the actual anatomy related to the pelvis itself and the interaction between our urinary and reproductive systems in terms of location. Okay, so the main supportive structure that you guys should know is this broad ligament. And they call it the broad ligament because it's a very broad and wide ligament. So it's going to spread out on both sides of the uterus. It's shown on just this right half over here. It's cut away on this left half so we can see a cross section. And so the ovaries don't actually attach directly to the fallopian or uterine tubes or the uterus itself. So this broad ligament helps to keep the ovaries and uterine tubes in close proximity. We have a couple other smaller ligaments like the ovarian ligament, and that's going to anchor the ovaries to the uterus. So it just provides some support and structure to help them stay in place. And again, the suspensory ligaments will anchor our ovaries to their space in the pelvic cavity. So our ovaries, in a sense, that are shown right here and right here are kind of floating without these ligaments to keep them connected or in close proximity to the fallopian or uterine tube. This uterine tube is not actually connected to the ovary. It's just kind of surrounding the opening. We also have the mesovarium, and this helps anchor the ovaries to the broad ligament. So the broad ligament kind of expands all the way out. It keeps our uterus supported and the fallopian tubes in place. And then this portion of the broad ligament, the mesovarium, is how the ovaries actually attach to the broad ligament. So here's that word gonad again. So the word gonad is going to refer to our primary reproductive organ. In the males, we had the testis or testes. In the females, we have one ovary or two ovaries. And this is one that I think students can mix up a lot, just like in the male system. So just to review again, our primary sex organ, our male gonad is going to be the testis our primary female reproductive organ is going to be the ovary. And we'll see that word copulatory organ that we talked about with the penis in the male system, and that would be the vagina in the female system that is involved in the actual sexual process, the reproductive process. So, difference between gonad and copulatory. You got to keep that in mind. That's an easy one to mix up. So our ovaries, because they're that primary reproductive organ, are going to be responsible for production of our oocytes, also known as egg cells, as well as the female primary sex hormone. And we'll talk about the hormones on their own a bit later down the line. So like I said, there's two different ovaries, one on either side of the uterus. And here's a reminder of what I just said a couple slides ago. They do not directly attach to the fallopian tubes. All those ligaments help keep everything in place and in close proximity, so that the fallopian tubes are still able to collect the oocyte released by the ovary. Within the ovary, we have what are known as ovarian follicles, and these are cells that actually contain the oocytes. So the oocytes are going to more or less live within a follicle, and we'll talk about what happens when FSH, follicle stimulating hormone, is introduced to the system and how that affects the follicle. And just another reminder, an oocyte is kind of our official name for the egg cell. That's our female reproductive cell. So for fertilization to occur, the sperm must meet and fertilize the oocyte. And another reminder from our intro material, once that oocyte is fertilized, we then call it a zygote. All right, just like spermatogenesis, I'm going to kind of give you the brief overview. It's a little bit different. I kind of talked about how we go from one cell with a full recipe all the way down to four cells with only half the number of chromosomes. It doesn't quite work that way in the female system, but the end product is our final oocyte that has haploid chromosomes, so 23 total chromosomes. So for spermatogenesis, we end up with multiple sperm cells that are viable. Oogenesis is a little different. So we're really going to end up with one really good, ready to go oocyte after this process. Another difference between male and female is that this process is going to begin before a female is even born. By month 4 of development, so by month 4, the fetus is going to contain 5 million oogonia. So these are immature egg cells. They're not ready to be fertilized, but they are ready to mature further. So females are born with all of their oogonia. So males don't really start producing sperm until puberty. Females are born with all of their oogonia. And they actually lose about 3 million of those, over half, just between that month 4 all the way through birth. And eventually, once females hit puberty around age 11, 12, 13, then we're going to have 300 to 400,000 oogonia left. So these are going to continue to decrease throughout the lifespan as women go through menstrual cycles. So this number is going to continue to decline. So much different than the male system, where we said if all the hormones are kind of staying at the right levels and we have the nutrients necessary, we can continue to produce sperm throughout the lifespan. For females, we just said they're born with all their oogonia they'll ever have, and that number will continue to decrease across the lifespan. So from puberty to menopause, we're going to go through this cycle of hormones, and the start of that cycle is FSH stimulating several of our follicles, the ovarian follicles, to begin developing. We'll talk about this whole hormone cycle. So even though we develop multiple follicles with the introduction of FSH, only one follicle should go through the process of ovulation each month or each cycle, and that is driven by LH. But like I said, we are going to talk all about those changes. So the ovaries and the ovarian follicles contain the oocytes, But that is not where fertilization occurs. That oocyte is going to enter the uterine or fallopian tube. If you look back to that image, you can see there's these little extensions that almost look like fingers that surround the ovary from the fallopian or uterine tube. We call those fimbriae, and they kind of collect or sweep the oocyte into the uterine tube. If sperm is present in the uterine tube during ovulation, during the release of that egg cell, that's when the kind of the best chance of fertilization to occur. So if a woman or a couple is trying to get pregnant, then they typically will track the cycle because they want to introduce sperm around ovulation when the egg is going to actually enter the fallopian tube. Of course, if fertilization occurs, then we get a zygote. That zygote is going to implant into the uterus. We'll talk about that in a little bit. And I told you to kind of keep in the back of your head that sperm live for 72 hours. Oocytes only live for 24 hours. So it's a relatively small window around ovulation where fertilization can actually occur. If fertilization doesn't occur within that 24 hours, that oocyte is going to die. The follicle that released it is also going to kind of wither away, and we'll see that results in a drop off of our hormones. All right, so the uterine tubes, are very commonly called the fallopian tubes, are this portion of the uterus. And so they extend all the way out to almost surround the ovaries with these fimbriae. And so, like I said, these are almost like fingers or extensions that help sweep that oocyte into the uterine tube once released. This mid portion of the uterine tube, known as the ampulla, is where fertilization actually occurs. So the ampulla of the uterine tube is where fertilization actually occurs. We mentioned in the male chapter or male segment of this chapter that the vas deferens or ductus deferens is what is cut in a vasectomy. In females, tubal ligation, or in a sense, tying of the tubes, for a less scientific word, is when we are kind of preventing the uterine tube from being fully accessible to the uterus. So even if an egg cell can enter, there's no way for it to get to the uterus to implant. So that would be tubal ligation in a female. Okay, the uterus itself is very important because this is where implantation itself is going to happen, and it's also going to provide a lot of nourishment for that fertilized zygote. And then eventually, of course, the embryo and fetus. So the body of our uterus is the main portion. So this kind of midsection would be the body. The fundus is where the fallopian tubes or uterine tubes enter. So if you kind of remember those as fallopian tubes, you can think F for fundus, F for fallopian. They go together. And then we have this narrow inferior portion called the cervix. And so this is also known as the birth canal because the fetus, or at that point, the child, is going to then exit via the cervix prior to reaching the opening of the vagina. All right, our uterine layers are also very important. The perimetrium is our outermost layer. It's more of just a protective covering. It's actually a serous membrane, if you remember our different types of membranes. And the two middle and most inner layer are the ones that we talk about more functionally. So anytime we see this word myo, M-Y-O, we always know we're referring to muscle. So anytime you see myo, your brain should think muscle. So the myometrium is composed of smooth muscle. So women do not control this layer of the uterus. It's smooth muscle, involuntary. It's the middle layer, so M for myometrium, M for middle. And this is what's going to contract during both menstruation and childbirth. The endometrium is also an extremely important layer. It's the innermost layer, and it's highly vascular. So remember, the word vascular means it's going to have a really good blood supply. That makes a lot of sense because blood is how we get nutrients to an area, and our endometrium is the layer that the ovum implants in. The oocyte or that zygote will implant on the endometrium. And so we said that's how we have to nourish that zygote and eventually the embryo. So we need a highly vascular layer that can bring a lot of nutrients and oxygen to that area. If implantation doesn't happen, this is the layer that's going to be sloughed off during menstruation. And like I said, we'll go through kind of the whole cycle later on in this chapter. All right, we mentioned this back in chapter 18, but just a reminder, if we're going all the way posterior, you can see the sacrum kind of making that kyphotic curve down this way. The rectum is here, and then anterior to the rectum is going to be the vagina. And then we have the bladder here. So the bladder's most anterior. And then we have the uterus that is superior to both the bladder and the vagina itself. And so that's the cervix that would open to the vagina. And so this is one of the reasons, as we spoke about in chapter 18, that when women are pregnant, they end up having a bit of a smaller bladder because that uterus is going to expand right on top of the urinary bladder. So the uterus, of course, allows menstrual flow if that endometrium is sloughed off. It has the cervix, which is part of the birth canal. So the cervix and then the vagina is the birth canal. And it's considered the female organ of copulation. So we said copulation means it's involved in sexual intercourse. So in males, the organ of copulation is the penis. In females, the organ of copulation is the vagina. Both the uterus and vagina are very muscular. So it's really got a muscle layer here that you can see. That's the majority of its structure. And it's also lined with mucous membranes. So mucous membranes always line our openings to the external environment. And this final bullet is very important to keep in mind as well. It's very acidic compared to the pH of the body, but that's because it wants to keep bacteria out. So just like the gut, the vagina has good bacteria, good microorganisms that are used to that pH. So if we kind of maintain that more acidic pH, we can keep the healthy bacteria growing and the unwanted bacteria will not want to live there. This is also kind of a reminder that part of the secretions that contribute to semen from the prostate gland and bulbourethral gland are going to help protect the sperm cells against this acidity. Okay, the vulva and the mons pubis are all considered external female sex organs. And so the mons pubis is this fatty layer of skin. It covers up the pubic symphysis. So the joint where both halves of the pelvis meet is the pubic symphysis. And typically, this is an area that will have hair growth after puberty. The labia majora and labia minora. So the labia majora are the outer portion, the labia minora are the inner. And so we have larger outer folds that are going to kind of surround that entrance to the vagina and again are going to be covered with hair after puberty. This is kind of our homologous structure in the female system for the male scrotum. So the scrotum and the labia majora are kind of the same thing. Obviously not because they are two different systems, but that's what that word homologous means, synonymous to the male scrotum. So labia majora and scrotum are kind of the same, but different male versus female. Labia minora are going to be much thinner. They're also going to be hairless, but they're still just folds of skin that are surrounding that opening. A couple of other external structures to be aware of. We have the clitoris itself is going to be the erectile tissue in the female system. It's located in what we call the vestibule. So the vestibule is this opening area. And in this case, this is our homologous structure to the male penis. The prepuce is this kind of layer of skin that goes over the clitoris, and that's really the meeting of the two labia minora. And I just mentioned the vestibule is this space. So both the vagina and the urethra are going to be located within the vestibule. The clitoris is at kind of the very superior portion of the vestibule. Okay, I mentioned mammary glands very briefly when we looked at the female reproductive system to start this lecture, but these are going to be in the breasts and they produce milk. And they really start off as sweat glands that are then modified to be able to produce milk. We're not going to go super in depth on these, but I'll kind of hit the big points. There's a lot of adipose tissue in the breast that covers up these lobes of our mammary glands. So they're organized into these sections. And so these lobes have ducts and lobules that are kind of going to go through a process of alteration so that they can actually produce milk during lactation when a female is actually pregnant and needs to produce that milk. So we call that process lactation. And like we said, they're normally only functional due to pregnancy and the hormone changes that occur. So the hormone prolactin, think promotes lactation, prolactin is going to be responsible for a lot of these changes. And then the what's termed as the letdown reflex, what actually allows milk to exit these lobules and go to the nipple, is going to be controlled by oxytocin. So prolactin and oxytocin are going to be the main hormones that contribute to this process. All right, female puberty is usually a little bit earlier onset and finishes more quickly than male puberty. So average onset is anywhere from 11 to 13 and oftentimes is completed by age 16. Now, that doesn't mean you're not going to get taller or other growth factors are not going to continue, but true puberty is usually completed around age 16. This term, menarche, is the first episode of menstrual bleeding. So that is what kind of characterizes the onset of puberty in the females. And so the vagina, uterus, the uterine or fallopian tubes, and the external genitalia we just talked about are going to get larger, and fat is going to be kind of preferentially deposited in the breasts and hips. This is when we're going to get a pretty significant increase in levels of estrogen and progesterone by the ovaries, and that's going to help us kind of contribute to development of secondary sex characteristics and some of the other hormone feedback cycle that occurs in the female system. So this slide should look very similar from the male reproductive system lecture, but obviously we have a little bit of a different function going on here since we have different anatomy. So we still start with the same first domino. GnRH, gonadotropin releasing hormone, is still going to be our first domino. Remember, this is produced in the hypothalamus because it's a releasing hormone, and it's going to knock over our next two dominoes, LH and FH. So both LH and FSH come from the anterior pituitary. I'm going to actually jump down to FSH first because we'll see when we start talking about the cycle of hormones in the female system. This is the first one we discuss, and it's going to prompt those follicles that contain our oocytes to mature. So the presence of FSH is going to begin maturation of those ovarian follicles. LH is going to come into play kind of in the middle of our cycle, and that's what causes ovulation. So that's the big term to remember. Anytime you see ovulation, you know there was a spike in LH. That's the one that is controlling that process. So estrogen is really one of the primary female sex hormones. I think if you had to pick one between estrogen and progesterone, I would say estrogen would be the primary one, but really both of them are secreted within the ovary and are very important. In terms of the menstrual cycle, estrogen is responsible for proliferation of the endometrial cells. So after that layer is sloughed off, we need to kind of rebuild our endometrium. And the first step in that is an increase in estrogen, so those cells will divide and proliferate. It also helps development of the mammary glands. And so I mentioned prolactin and oxytocin, but estrogen has a role in this as well. And I also mentioned that our female system kind of controls our cycle with a balance of hormones. So based on our estrogen levels, that's partly what will control when LH and FSH are secreted. And again, development and maintenance of the secondary sex characteristics, just like testosterone in the male system. Progesterone is kind of our 1B for our female hormones. So like I said, if I had to pick one, I would say estrogen is primary, but progesterone has a very, very important role as well. It comes along a little bit later in the cycle, and it's responsible for enlargement and vascularization of the endometrium. It's also going to cause secretion of fluid from the uterine glands, all related to preparing that endometrium for implantation and development of a zygote or embryo. This also helps us maintain that pregnant state. So, like I said, I've said this a couple times. We'll talk about the cycle at the end of this lecture. But if we don't have implantation, progesterone and estrogen kind of drop off a cliff. We lose the levels go down very quickly. If implantation does happen and we need the female system to maintain the pregnancy state, prolonged secretion of progesterone and maintaining progesterone levels is primarily responsible for that. Again, helps development of the mammary glands, and that feedback system goes with all of them. So it's going to control estrogen, FSH, and LH secretion. Again, also helps with development of secondary sex characteristics. That's part of the reason why I don't think you can really say estrogen's primary, progesterone's secondary. They're both very important. So I kind of term it more like 1A and 1B. Okay, so let's see how they interact with one another. So up top, we see the pituitary gland hormones. So that's going to be LH and FSH. You have a little reminder that GnRH is coming from the hypothalamus first. This is showing you what's going on in the ovary itself. And then we have our estrogen level here, our progesterone level here, and then our endometrial level. So if this bottom row, when we have a kind of a higher spike or this buildup, that means the endometrium is getting stronger and or larger and more vascular. And then we see this drop off is when it is sloughed off, assuming where there's not implantation. So just to kind of orient you guys to that. So the average cycle is 28 days, and this cyclical secretion and feedback system of our hormones is what controls this. And so the menses itself is when the endometrium is being shed from the uterus. So in our graph here, right here, and right at the very beginning is what we would consider the menses. So that endometrial layer is sloughing off. Along with this menstrual cycle, we'll talk about the ovarian cycle, which is what's actually happening in the ovary up here. That kind of corresponds to what's happening within the uterus. So the very first day of the menses or the period is the first day of the menstrual cycle. So that is when the endometrium is actually sloughing off. There's going to be bleeding because you have actual blood and tissue. That endometrial tissue is leaving via the cervix and vagina. And so that means that implantation did not happen. So estrogen and progesterone levels are going to be very low at that point. This is also when we're going to start bumping up secretion of FSH because we want to start maturing the next group of follicles. So the second part of the menstrual cycle we call the proliferative phase. And so I would keep that in mind because it goes hand in hand with estrogen levels increasing, which we said is responsible for proliferation of that endometrium. The endometrium had just been sloughed off during the menses. So now we need to rebuild that endometrium. And the first step of that process is estrogen levels increasing. You'll see we have this bigger spike here now. but progesterone is still staying down lower. So we need estrogen to do its job first. Within the follicle itself, now we're getting to a fully mature follicle containing a mature oocyte as we get our FSH levels all the way. Okay, right in the middle, day 14, on average, is going to be ovulation. And that's characterized by this really big spike in LH. And so, what happens in ovulation that we see here is the follicle is actually releasing the oocyte, which is going to then enter the fallopian or uterine tube. Another thing that I want to point out with ovulation is that that follicle is not going to disappear. It's actually going to stay around, and we call that the corpus luteum. So keep that in mind because we're going to mention that here in a second. So that spike in LH causes ovulation, which is the release of the oocyte. Our estrogen levels are still high, and now progesterone levels are going to increase because we really need to vascularize and grow that endometrium in prep for implantation. So now we see progesterone levels increase. And along with that, we see our endometrium is building up. So that follicle that just released the egg is known as the corpus luteum, and it is going to actually secrete progesterone. So that's why we get that spike. So after ovulation, this corpus luteum is what is secreting progesterone. And so if the egg is not fertilized, it's going to degenerate. So now we no longer have our progesterone secreting structure, and we get that decrease. The last phase is the secretory phase. So at this point, we just talked about progesterone levels increasing and preparing for implantation. Our estrogen levels are low at this point. It kind of already did its job. We just said progesterone is high, and we're going to get a thickening of the cervical mucus. If fertilization does not occur, like we just said, our corpus luteum that was secreting progesterone is going to degenerate, and that causes that drop off. And so this drop off in both progesterone and estrogen is kind of what triggers that sloughing off or the menses to occur. Before I pop up, so let me just kind of remind you. So we said when we talked about progesterone that it's important in maintenance of the pregnancy state. So if this drop did not happen, if this corpus luteum stayed around because the egg was fertilized, instead of going down this way, we'd get a little bit more of a leveling off so that we maintain the health of the endometrium versus sloughing off. One other thing that I wanted to mention briefly, we use 28 days, 4 weeks as our kind of average cycle, but it's not atypical for a woman's cycle to be shorter or longer than that. In general, a woman's cycle should stay kind of on the same average. So you shouldn't necessarily be 40 days 1 month, 15 days the next month. It shouldn't bounce back and forth. That means there's something going on with the hormone cycle. But we use 28 days kind of as our average. That's not a set in stone thing. So I just want to make that clear. Okay, menopause is a pause or really a stop of the menses. And so this is when our ovaries are going to secrete much less hormones, and we also have much less viable follicles in the ovaries as well. And because this hormone cycle is no longer going to continue in the same way, it means that menstrual cycle and ovulation are going to be much less regular, and eventually that's going to come to a complete stop. So some of the common symptoms that are associated with menopause are hot flashes, fatigue, and irritability. And this all has to do with our kind of the female system being so used to this hormone cycle that has been regular for a very long time. And so the body is getting used to not having these same levels of hormones cycling on that regular cycle. Estrogen replacement therapy can be used to help decrease some of these side effects because, in a sense, you're adding some of that primary hormone back to the system, which is no longer secreting as much of it. I'm going to kind of go on my soapbox for a quick second. This is something that was for a long time really looked down upon or kind of anti-estrogen replacement therapy because there was a concern for increased cancer risks, especially breast cancer was one of the main studies that really put a halt on estrogen replacement therapy. So, of course, everyone should consult with their doctor. Kind of each individual is going to vary, but estrogen replacement therapy is definitely safe. And while there may be a really mild relative risk increase, there's a lot of benefits that outweigh the true risks. So it's not something that is taboo at this time in medicine. It's really making, I guess you could say, a comeback because it is safe when done correctly. All right, just like we ended our male reproductive system, we're going to touch on the sexual behavior for the female system. And so, sex drive in females, just like in males, is going to depend on our hormone levels. So, this is another kind of important concept here. Just because testosterone is the primary male hormone and estrogen is the primary female hormone does not mean that females have zero testosterone and males have zero estrogen. There's a balance in levels based on the different systems, but both hormones are present in both sexes. And so these testosterone-like hormones are going to be produced within the adrenal cortex and have a large influence on sexual behavior. Of course, there's a lot of psychological factors that play a role in sexual behavior as well. We're not going to go super in depth into those. And the actual sensory and motor pathways that we discussed in the male system are going to be pretty similar in the female system. Again, of course, we have different anatomy, so the physiology is going to be slightly different, but the overall process is very similar. So we said the clitoris is the erectile tissue within the female system. And so it becomes engorged with blood when that vasodilation happens. The mucus glands within the vestibule, within those mucous membranes, are going to secrete small amounts of mucus. And deeper within the vaginal wall, there's going to be a larger amount of mucus that begins to be secreted. And this is to facilitate copulation. The overall climax experience is very similar to the male system as well. So both the vagina and uterine smooth muscle and the skeletal muscles within the pelvic floor and abdomen are going to contract rhythmically, and muscle tension kind of increases throughout a majority of the body. So this is where it gets a bit different from our male system. There's still a period of resolution, so there's that kind of overall relaxation that happens, but the female system does not have a refractory period as seen in males. So in males, we said that refractory period is the timeline where the system is resetting in a sense. They're going to be unable to achieve orgasm or climax. That portion does not exist in the female. So resolution is in both systems, but the refractory period only applies to males. And that wraps up chapter 19. So I will see you in chapter 20 for our very last lecture. You guys are almost there.